Our last session is on orthostatic and autonomic disorders. And I'm very pleased to introduce Dr. Peter Rowe of Hopkins, who will be the first of our two speakers in the session. Dr. Rowe is well known to many of you. He basically put on the map the link between or among POTS and ME/CFS and orthostatic intolerance and ME/CFS. I've learned today that he's Canadian. He got his undergraduate degree at the University of Toronto and his MD at McMaster U. And then in part because the Leafs have not won a Stanley Cup since 1967, he moved south where he's of the border and has remained here since. He did his pediatrics residency at Johns Hopkins and a fellowship at Robert Wood Johnson, and went back to Hopkins where he's remained since. He's a professor of pediatrics and directs the ME/CFS Center there. Dr. Peter Rowe, thank you.
Thank you, David. And as some of you saw from Dr. Systrom's talk the other day, he had an iconic figure in the beginning, this guy who's the quarterback for the New England Patriots, Tom Brady. And I was concerned as a Baltimorean now about Tom's health because he was standing still and upright. And, you know, in Baltimore, we wouldn't want that to continue because he could get lightheaded and tired. We got a clicker. So this is what we try to do when Tom comes to Baltimore is we try to get him to a safer position, very gently. Okay. So I'm going to talk a little bit about orthostatic intolerance. We've heard a number of speakers mention that throughout the couple of days. We'll talk a little bit about the symptoms that we see, why we associate it with ME/CFS, and along the way I'll talk about some gaps in the way we define orthostatic intolerance symptoms, how we characterize the signs of orthostatic intolerance, and then some new findings that I hope will be relevant, especially given the talks that Mike and Jared just gave. So the general definition of orthostatic intolerance is that it refers to a group of clinical conditions. And often we hear that POTS is the only form of chronic orthostatic intolerance. That's simply not the case. It gets repeated a lot. But this is a group of conditions in which symptoms worsen with quiet upright posture and are ameliorated but not abolished by recumbency. And the problem that we have is that the persistence of symptoms after a single period upright can be quite prolonged. After a faint, we've known since the 1920s, you can get 3 days of exhaustion and tremulousness. So often the symptoms of orthostatic intolerance seem unrelated to the specific orthostatic stress. The big physiologic challenge we face in standing up as humans is that there's a shift of blood volume of about 500 to 750 mils into the lower half of the body when we stand. This cartoon from Philip Lowe's book on autonomic dysfunction shows the distension of the veins in the right-hand figure in the areas below the heart. What it doesn't show well is the fact that there can be a lot of splanchnic pooling, so the abdominal circulation ought to be much more expanded than it appears in this cartoon. The normal response to that shift of blood into the lower half of the body is a drop in arterial pressure. That leads to less stretch of the arterial baroreceptors in the thorax and the neck. The neural message to the cardiovascular nuclei leads to a slight reduction in vagal tone and a big increase in sympathetic nerve outflow from the CNS. That leads to about a 10 or 20 beat increase in heart rate, a little bit of improvement in stroke volume, and the major influence on our ability to remain standing is that there's an increase in sympathetic nerve activity that improves vasoconstriction. That shifts blood back up to the heart and the brain, and then the brain calms down that sympathetic outflow. When this process does not function efficiently, how do I go back? When that doesn't function efficiently, you get these symptoms. of orthostatic intolerance, which, as anyone can see, overlap tremendously with what we see in ME/CFS. The ones on the left are thought to represent symptoms due to inadequate cerebral blood flow, so lightheadedness, fainting, poor concentration, headaches, blurred vision. Every form of orthostatic intolerance has an increased prevalence of fatigue and exercise intolerance. The ones on the right partially are related to the high catecholamine levels that are in response to the reduction in cerebral blood flow. So we can see an orthostatic dyspnea or shortness of breath, chest pain, palpitations, shakiness, anxiety, and so on. One of the signs that we'll see, and I'm not sure how well this projects, is acrocyanosis. So patients will get this purple discoloration of the dependent limbs. On the left is a young college student who had to stop college because of her level of lightheadedness and fatigue. And this is her hand after about 4 minutes of standing, with my hand behind it as a color contrast. On the right, I went over and did a capillary refill test, so you can see the imprint of my fingers. I stepped back, found the cell phone, fiddled with it, tried to find the photography part. It took me about 8 seconds, and I took this picture, and you can see no capillary refill, which is really profound. And if this patient had been an ICU patient, we would have had her on a dopamine drip. So it's really quite an astonishing, dramatic clinical finding in many of these patients. We started looking at the overlap of orthostatic intolerance and CFS back in 1995, and we were looking at a group of patients who were recruited from a patient support group, one in Hagerstown and one in Richmond, because the Baltimore groups wouldn't come to anyone at Hopkins because previously they'd been sent immediately to the psychiatry department. In any event, we saw lightheadedness by history in almost everybody. Many of them had sweating, blurred vision, and 43% had at least one prior episode of syncope. The conditions that exacerbated their fatigue, in addition to physical exertion, which is part of the definition, were things that involved quiet, upright stress, especially in hot environments. So a hot shower was particularly troublesome for them. Prolonged standing, like waiting in line at the store. A hot day, and after a lightheaded episode. We had 23 CFS patients in this study, and one of the striking factors that has persisted till this day is that when we tilt them upright to 70 degrees, they develop an increased level of fatigue, a bad day for their ME/CFS. 20 of the 23 were lightheaded, 20 had a sense of warmth or a hot flash, 16 were nauseated, and 4 had excessive sweating. Whereas the controls, exposed to 45 minutes of upright tilt, were simply bored. Others have extended these findings over time. Julia Newton's group in England has shown much more sophisticated methods. They used the COMPASS autonomic symptom questionnaire, showing that CFS patients were much more likely to have high scores on autonomic dysfunction compared to controls, and the COMPASS scores correlated with their fatigue levels. Others, like Julian Stewart on the right and Marvin Meadow, his colleague on the left, have shown that orthostatic stress is capable of causing the brain fog that we typically see. So as the level of tilt goes up, patients make more and more errors or have more delayed responses. All of this data led us, when we were summarizing the literature in the Institute of Medicine Committee, to conclude that sufficient evidence indicates a high prevalence of orthostatic intolerance in ME/CFS as measured by objective heart rate and blood pressure abnormalities during standing or head-up tilt, or by patient-reported exacerbation of orthostatic symptoms with standing in day-to-day life. These findings indicate that OI is a common and clinically important finding in ME/CFS. There are some gaps in how we elicit and classify orthostatic symptoms. So in the autonomic literature, if you list symptoms like difficulty thinking or fatigue, the autonomic experts directly attribute that to the circulatory problems and lack of blood flow to the brain. In our field, fatigue and cognitive difficulties are often assessed independent of the person's position and posture, of the degree of orthostatic stress, and they are often attributed to some aspect of the illness itself rather than connected to the upright posture. And that's a bit of a problem in the way we elicit the symptom. We need to do a much better job sorting out when it occurs. There are also gaps in how the hemodynamic abnormalities are elicited. So the group in England wondered, could you do a shorter, abbreviated standing test or tilt test to diagnose the prevalence of POTS? And so this is a paper looking at our own data where we had patients with confirmed POTS during 10 minutes. POTS is defined as a 30-beat increase in heart rate for adults, 40 for adolescents, over 10 minutes of standing with reproduction of their symptoms. And if you look at this life table analysis, if you stopped at 2 minutes, you'd miss 53% of those who truly have POTS and would potentially be denied therapy because they were said to be normal. Similarly, others have said 5 minutes should be sufficient, but with a 5-minute test, you're going to miss 27% of those who truly have POTS. We also found that you needed to check the heart rate after the end of the test because some, at least adolescents, before the test had a higher than normal baseline heart rate, so it didn't give you an accurate reflection of their usual resting supine heart rate. We found that the similar life table analysis is present in adults who are tested with tilt table testing, not just the adolescents with a standing test. The Institute of Medicine criteria suggested we needed to look at orthostatic intolerance and count as a core feature of the illness, but we didn't in that document provide much on operationalizing how you measure orthostatic intolerance. So an example of the problems from a cohort study we did in adolescents and young adults, we said orthostatic intolerance ought to be defined by questionnaire if you have lightheadedness at least several times per week. And we had 42 out of 55 who endorsed that. We also had 5 who had a pre-study diagnosis and were on treatment for their orthostatic intolerance, so they didn't endorse the questionnaire response. They had less frequent lightheadedness. That brought the cumulative prevalence up to 84%. In the remaining patients, we did either a standing test in the clinic we did a passive standing test in the clinic, and 6 more had POTS or neurally mediated hypotension, and the 2 others had worsening of their symptoms on the passive standing test, keeping in mind that a passive standing test only goes for 10 minutes. So in our experience, orthostatic intolerance is present in about 100% of these patients if you look properly. If we summarize the physiologic literature on orthostatic intolerance, there are 2 main things that seem to contribute to the problem. One is an increased amount of pooling of blood in the peripheral, in the limbs and the dependent circulation, and a defect in vasoconstriction. The other thing that's been documented by a number of groups, and I think most elegantly by Nancy Klimas's colleagues, is that there's about a 10% reduction in circulating blood volume in these patients for reasons that we don't understand. Those 2 factors combined mean that when you undergo orthostatic stress, either with standing or tilt, there is ultimately a reduction in cerebral blood flow. That elicits a big sympathoadrenal response, and then the phenotype of the circulatory response that you might see is at the bottom. So you could see orthostatic hypotension in the first 3 minutes. You could see delayed orthostatic hypotension after 3 minutes. You could see the vasovagal or neurally mediated hypotension response. You could see POTS. And then a large proportion, especially of the adults, have what seems to be a normal heart rate and blood pressure response. When we looked at the literature, and this is meant to be unreadable, so don't try and get at each individual study. When we looked at the data for the Institute of Medicine report of the 14 studies where prolonged tilt testing had been undertaken, we saw the summary was 42% of ME CFS patients had orthostatic intolerance in the first 45 minutes, and that compared to 15% in the healthy controls. But the variability in studies was tremendous. Some reported no patients with CFS having orthostatic intolerance. I find that hard to imagine. I'm not sure that those were patients that were anything like what we see. And this was up to 79%. But it may be that when we're looking at the phenotypes for hypotension and POTS and so on, we're looking in the wrong place. If the symptoms are due to decreased cerebral blood flow, maybe that's where we ought to focus. And the next few slides are with permission of Frans Visser and Linda van Kampen from the Netherlands, two cardiologists who have developed a new method of measuring cerebral blood flow. Our earlier methods used to involve transcranial Doppler to look at cerebral blood flow velocity, but not total flow, or scans that were done with the patient supine, which obviously wouldn't pick up what we're looking for. They came up with a technique for looking for cerebral blood flow changes during tilt using Doppler imaging for a few seconds each on each carotid and each vertebral. So you're getting all of the inflow to the brain. And what they showed was that by the end of tilt, there was a 6% reduction in cerebral blood flow for healthy volunteers. When they looked at the patients with ME/CFS who had normal heart rate and blood pressure responses during tilt and would otherwise have been said to have had a negative study, what they found was quite profound. And that was about a 20% reduction at the end of tilt, which was a 20-minute tilt, in cerebral blood flow. In those with POTS and hypotension, it was closer to 28% reduction, so really quite a profound change. Almost all of their adult patients had this kind of reduction. So I think that needs to be part of the discussion about the neuroinflammatory causes. Could they be related to cerebral underperfusion? I'm not sure we've ruled that out just by doing scans with patients supine. They also looked at the question that is raised often by the cognitive behavioral theologians, as I call them, because they don't take into account the autonomic data. They assume that everybody who's dizzy and lightheaded simply is deconditioned. So Linda took a look at those who'd had a cardiopulmonary exercise test, ranked them whether they had greater than 85% of their VO2 max or less, and they didn't differ from one another. So whether you were deconditioned or not, you still had a reduction in cerebral blood flow. And if they matched people on the number of steps, which you see on the left side of this slide, smaller numbers, you could still see that even though the steps were the same, those with ME/CFS had close to a 25 to 30% reduction in brain blood flow. Orthostatic intolerance, as you've heard from Cindy Bateman, is one of the most treatable problems that I've encountered, that many of us have encountered in this illness, and this was from one of our early studies in 1995 showing that with open treatment using a variety of medications directed at hypotension, the overall wellness score in the patients went from about 35 up to about 70 after 4 months of treatment. The responses weren't uniform, but most people can be helped by this. So in conclusion, the majority of the adult, and although I didn't present this data, all of the pediatric studies show that orthostatic intolerance is strongly associated with the illness. Upright posture, we know, consistently aggravates the symptoms, even in the absence of heart rate and blood pressure changes, and often for days. Again, consistent with orthostatic stress being a cause of PEM. The cerebral blood flow reductions measured by the Doppler technique are substantial and clinically significant. And then just to end with a couple of thoughts about research needs, I think we need to understand better, and perhaps Dr. Oaklander will be addressing this, the causes of orthostatic intolerance in ME/CFS. So is this due to some high prevalence of anti-adrenergic and cholinergic autoantibodies, as Scheibenbogen's group has suggested? Is there a high prevalence of mast cell activation syndrome as a precipitating or perpetuating factor? What's the influence of the increased vascular compliance in those who have hypermobility or Ehlers-Danlos syndrome? And one can ask reasonably the question, is mitochondrial dysfunction a cause or a consequence of the impaired circulatory control? One thing, though, that I want to come back to, and Betsy Keller made this point the other day, is that patients need treatment. The open treatment of orthostatic intolerance is associated with improvement in fatigue and other symptoms. And I think we need much more funding for clinical trials and practical studies to help provide an evidence base for practitioners who might otherwise not be inclined to try to manage orthostatic intolerance as a way to improve function. Lastly, orthostatic intolerance syndromes are heterogeneous, and we teach our trainees that we need to continually ask, orthostatic intolerance due to what? We published last year a series of 3 young women who had full-blown ME CFS by anybody's criteria. All of them had orthostatic intolerance, and all of them eventually had abnormalities on their neurologic examination, either really brisk reflexes or a positive Hoffman sign or both. And the slide on the right shows the cervical spine MRI for one of these patients that I had followed for 6 years. She eventually got a positive Hoffman sign. We got the C-spine MRI, and she had cervical spinal stenosis on a congenital basis with a canal diameter of about 8 millimeters. Normal is more than 13. And at C5-6, she had a small disc bulge that might be inconsequential for most people, but it was enough to cause indentation on the cord. Her orthopedic spine surgeon said, I don't know about this fatigue and tachycardia stuff, but you need that disc replaced or else you're going to get into trouble in a car accident. With the disc replacement, she had a full recovery over the next 9 months and has done well for 5 years since, now rock climbing, fully active, working full time, and not only did her POTS resolve, but so did her anxiety. And we had 2 other patients with very similar functions, one of whom recently sent me a picture of her being loaded into the ski patrol tray because she'd torn her ACL skiing. And as we say, we don't need no damn p-value for that one. So I'll end there. This is just a word of thanks for all those who have supported our work over the years.
Time for questions here.
Okay. Oh, okay.
Thank you very much, Dr. Rowe. We have time for a couple of questions.
Great.
Presentation. Can you just comment on the clinical observation that we see symptomatic improvement in women when they become pregnant in this group in patients with ME CFS?
Yeah, it's not uniform, but we see it fairly often. And we think the reason is that if you're starting off with some degree of hypovolemia, part of the normal physiologic response in pregnancy is about a 2-liter expansion of blood volume that kicks in by the end of the first trimester. So some of our patients, we learned this from the mothers of the adolescents we were treating when we took their history, and they said, yeah, I had this lightheadedness stuff until I got pregnant, and that was the best I'd ever felt. And the young women often will say that. I don't think that's a really common report from women who are pregnant. They might be blissed out and happy that they're pregnant, but they don't feel physically better than they've ever felt before. But that's something we hear from our ME CFS patients a lot. And in my clinic, what I do is I then say to the parents of the adolescent girls that they should get those girls pregnant often. And that's a test of whether they're going to tolerate my sense of humor from then on.
Can you tell us how you guide your patients about the role of exercise if they're trying to recover from
it's
this
a
condition?
Big question. One of the problems with, I think, the way exercise has been forced on people with ME CFS as if it's somehow curative is the sort of British pace type attitude that all you need to do is get off your lazy bums and get moving. And so there's been a reaction to that. There are some people who are harmed by excessive rigid advancement of exercise for sure. But in order to get where we want people to be to recover function, they've got to go from this point to this point, and the only way to do it is to increase their activity level at some point and with some level of support. I think the difference with how we approach it is that we want it to be flexible in patients who can tolerate it, and it's almost always the case that you've first got to support their circulation before they can advance to any kind of exercise. We find that the physical therapy stuff I was mentioning earlier today is another bridge to tolerating exercise. If they simply can't tolerate it, you have to find other ways to advance things slowly, gradually, and without provoking PEM. But I really think we are in trouble if we have such a strident opposition in this community to any form of activity, because when people are completely on bed rest, they lose about 18%, up to 18% of blood volume in 2 weeks. That's going to make their orthostatic intolerance worse. It will start a terrible downward spiral. So I think we have to have a much more nuanced understanding of the importance of activity for recovery, but also a recognition that our job as physicians is to support the patient in being able to tolerate that. Slow, gradual advancements.
Your last answer is very interesting to me. So my daughter, I live in Boston, she has chronic fatigue, and my niece who lives in Maryland, and I don't know if she was treated by you or not, she's 15 years old, and she just went on the Inca Trail. She just went to Machu Picchu. That's how much better she is. And I know that she did physical therapy, and after being kicked out of, she couldn't go to school. That's how bad she was with POTS. That's what her diagnosis was. And now she went to Machu Picchu and to Peru and was dancing and everything. So my daughter, first of all, do you see patients that are adults, or you only see adolescents?
I mainly see adolescents, and we're so jammed that it's very hard to get new patients in because there's no adult clinic to transition them to, and I've been following people for 25 years. There are a lot that we can't get better, and so I don't want to suggest that this approach works well for everybody. And those are the patients we struggle with the most. Some patients improve spontaneously as they get further and further away from their initiating infection. We don't understand that well enough, and why some people just don't seem to respond to much that we throw at them.
Okay, thank you so much.
Yeah, unfortunately, I think in deference to time, we'll have to take additional questions after the session. I'm sure Dr. Rowe will be around. Thanks.